do often tissue biopsy to detect sarcoidosis versus tuberculosis, etc., or malignancy. How easy it is to do a CT guided parenchymal biopsy?
So if there is a focal lesion in the lungs, it's very easy to do a CT guided biopsy. I mean, it's not a big deal at all.
Okay, and do you do it frequently at your center?
Yeah, every day.
Yeah, and the yield is good.
Yes.
The yield the tissue yield is good, so you can get a diagnosis.
Yeah.
Okay. Do you do mediastinal biopsies also?
Yes. So if they are approachable mediastinal lymph nodes or masses, then we do them.
So in a person with, say, mediastinal mass, what is a better investigation? An endoscopic transbronchial biopsy or a CT guided biopsy? Is there any such thing?
Yes. So if the mass is approachable with CT scan, then there is no question that a CT guided biopsy is simpler, faster, cheaper and better.
With less morbidity?
Less morbidity, you don't need hospitalization, you can use larger bore guns, you can take a lot more material, all of that. With bronchoscopy or EBIS, the challenge is that it's expensive, you have to hospitalize, the yield is still, they can only use 20 or 22 gauge. So if it's not approachable by CT scan, obviously you have to do an EBIS or one of these more invasive procedures, you don't have a choice. But when you have a choice, then CT or even ultrasound for that matter is always a better modality.
There are many forms of interstitial lung disease, and the form will decide the therapy. For example, hypersensitivity pneumonitis, which is a common form, requires maybe steroids, whereas IPF, that is idiopathic pulmonary fibrosis, requires other therapies like pirfenidone. How useful is transthoracic biopsy for interstitial lung disease, or imaging itself is good enough?
No, so biopsies for interstitial lung diseases have to be either VATS guided or open biopsies.
Okay.
Rarely transbronchial if you're suspecting sarcoid, but for diffuse lung diseases, we don't do CT guided biopsies. There is no role, it is only for focal diseases. But CT itself is very good for differentiating different forms of interstitial lung diseases. And in about 70% of patients, we can generally say whether the patient has IPF or hypersensitivity pneumonitis or sarcoid or connective tissue disease related ILD. We are able to make out. 30% we can't, especially. So again, in that 30%, if the patient is above 70 or 80, then it doesn't really matter because you can treat symptomatically even if you don't know what it is. But younger patients, 40s, 50s, then you would biopsy because you need to know which one it is so you can prognosticate and decide how to take this ahead.
Yeah.